Today we are having a long case discussion on solitary thyroid nodule benign in nature. The case will be presented by Dr. Nitesh Pradhan, who is a third year junior resident at MR Bangalore Hospital. And today's session moderated by Dr. Ditiman Moitra, who is assistant professor of surgery at Calcutta Medical College. And I'll also be there. So Nitesh, you can share your screen and start presenting.
Yes. Good morning, respected teacher. My patient Mrs. Pratima Haldar, 30-year-old lady, resident of Kolkata, occupation by housewife, came with a complaint of swelling in the front of the neck for last 1 year. History of present illness: the patient was apparently well 1 year back when his family member noticed a swelling in front of his neck. The swelling was insidious in onset, gradually increasing in size. Initially was size of approx 1 to 1 centimeter, which has increased to present size of approximately 3 × 3 centimeter, not associated with any aggravating factors. No history of pain over the swelling, no history of fever, loss of weight and appetite, no history of significant no history of symptoms suggestive of hyper and hypothyroidism, no history of irradiation to neck, no history of change of voice, dysphagia, dyspnea, stridor, no history of any other swelling in the neck, no history suggestive of distant metastasis.
Sir, discussion ki amra majkhane korbo na ki
at the end of history and then after examination.
ठीक है.
There is no history of any surgery, no history of any tuberculosis and its exposure, no history of any medication intake for chronic ailments. Personal history: patient takes mixed diet, no history of addiction, sleep, bowel, bladder, appetite are normal, married with 2 children with normal vaginal delivery, regular menstrual cycle of 28 days with average flow and 5 days duration. Family history: no history of similar illness in the family. Summary of the history: a 34-year-old lady presents with swelling for last 1 year in front of the neck, insidious in onset, gradually progressive from about 1 × 1 centimeter to 3 × 3 centimeter, presently with no symptoms suggestive of hyper and hypothyroidism and or constitutional or compressive symptoms.
Okay, Dr. Moitra.
What are the symptoms of hyper or hypothyroidism?
Go back to the history of present illness slide. In the first slide, you said swelling in the front of the neck. You find that patient having a swelling in the thyroid, either maybe from the isthmus, maybe the right or left lobe. So if you are finding that swelling is on one side of the neck itself,
Mention that.
the right side extending to the midline and history of illness. So if it is, you say midline, it appears that it might be arising with the isthmus.
Yes, sir.
Okay, so picture is not there, but you specify that because you are presenting a solitary nodule.
It is very difficult for students to comment. Sometimes if there is a big, like left lobe is so big that it appears that both the lobes are enlarged.
Yeah.
So how will you differentiate? Before you approach the patient, first 1 or 2 minutes you should give to form a provisional diagnosis in your own mind. What you will ask the patient is, you ask the patient to extend the neck completely and you try to feel the trachea. If the swelling is on one side of the trachea, then it is either a right solitary thyroid nodule or a left solitary thyroid nodule. A nodule does not necessarily need to be like a nodule. And even if the entire lobe is enlarged, but the surface is smooth, there are multiple nodules are not there, then you can call it a right STN or left STN. The only criteria is that it should be either on the left or right of the trachea. If it is difficult for you to fathom whether it is both the lobes enlarged or a single lobe enlarged, you always make the patient extend the neck and then you try to see the location of the nodule with respect to the trachea. And then you start taking history and form the, construct your case on the basis of that.
Yes.
And you have said lady, and then you have written his. These minor things, They're not important, but they carry an impression. How
Yeah, yeah.
careful you are.
It should be very perfect presentation.
Yes. Okay. So you have asked about not associated with any aggravating factors. What
That is
have you
also not
asked?
relevant. There is nothing
Why
called
have you
swelling in the
written that?
thyroid getting aggravated with something. It's not that. It's not necessary. Pain is something which is aggravated by some movement or some other features. Swelling cannot be aggravated by anything.
Yes. Next.
Hmm.
So you have taken history of pain. Why?
Sir, pain.
Name some thyroid swelling where pain may be a presentation.
Sir, in case of sir, a malignant transformation.
Malignant transformation is not the pain in the first thing. There are some other conditions where pain is a presenting symptom in.
Sir,
Itis, thyroiditis, inflammatory
sir,
condition.
yes,
Now,
sir.
what kind of conditions may be painful? What kind of conditions may be painless? You have to read that. Okay. Like chronic lymphocytic thyroiditis, Hashimoto's may be painless mostly, but if it is subacute, viral, or require one, these could be associated with pain. Or there may be an episode of fever when the swelling is, when the patient initially presents with the swelling. So you have asked about symptoms of hyper or hypothyroidism. So what?
But before that, he said weight
Sir.
or appetite loss. How
Hmm.
common is it to get a loss of weight and appetite in a patient who has got a differentiated thyroid cancer? Is swelling there, no other swelling in the neck. And if the patient doesn't have distant metastases, is it common to have loss of weight? But for sake of completion, you should ask. But you should always keep in mind that loss of weight and loss of appetite is not a very important feature of a differentiated thyroid malignancy.
Yes.
Rather, increased appetite, and in spite of increased appetite with weight loss could indicate hyperthyroidism or Graves' disease. So if you have written loss of weight or appetite, you write in greater detail. Like the patient does not have weight loss or loss of appetite. The patient does not have loss of weight in spite of increased appetite. Like this, you write 2, 3,
Yes.
This is more of a symptom of hyperthyroidism.
Hmm.
And another thing is it swelling in the any other swelling in the neck? I would suggest that once you describe a swelling, you have described the swelling from the one side of the neck, extending to the midline. At the same go, you complete whether patient notice any other swelling in the neck. So that completes the history of swelling itself. And at the same time, there might be swelling in any other part of the body. As you say, distant metastasis. So there may be a swelling in the scalp. There is swelling in the ends of long bones, which might suggest distant metastasis. So you can say that one go, swelling is described, no other swelling in the neck, no other swelling in other parts of the body. But you should keep in mind, who have asked that. Other parts of the body means bony metastasis, which can occur in follicular carcinoma. It can mean the scalp, it can be the end of long bones, humerus, femur. But you see, this history is important. In thyroid, your history should cover the swelling, number one. Number two, any constitutional feature, as you said, because you need to differentiate between the lymph node or some thyroiditis. Next, symptoms of Dr. Mohit was asking, what symptom you asked to say patient has got hyperthyroidism?
Sir,
because you need to, it's very important, you relate in one line. But to comment about that, you need to do a whole systemic symptom survey to say that yes, patient does not have symptoms of hyperthyroidism. What are the symptoms you ask? Start with the GI. Be methodical. You go by each system.
Yes.
Sir, GI, sir, the gut motility will increase in hyperthyroidism.
No, symptoms, you don't
give. Sir, patient presents with diarrhea.
Before that, another point is discussed already. Patient has increased appetite. In spite of that, patient may have loss of weight. Yes.
Diarrhea. Then
diarrhea.
Sir, what are other symptoms? Other systems?
Sir, other symptoms are like weight loss, increased sweating.
Cardiovascular.
Sir, palpitation.
And what else? A lot of things can happen. Palpitation is because maybe of only of tachycardia. Some patient can tell you that he is dropping beats. Some intelligent patient tell you that he's dropping beats. That means some form of arrhythmias. A lot of arrhythmias can happen in hyperthyroidism. Some intelligent patient tell you that I feel my heart is not beating. That is one of the present manifestations of palpitation. When the heart beats irregularly, patient will feel palpitation. Or patient has got tachycardia, patient palpitation. Apart from that, what other cardiac symptoms may occur?
Sir,
Can this patient present with some failure?
Yes, sir. Congestive heart failure, sir.
So what kind of symptoms?
Sir,
Everything can be there. Orthopnea, cough, early morning, air hunger, or everything can occur. Then
Left ventricular failure is more common than congestive cardiac failure.
Yes.
Congestive cardiac failure is a right side heart failure. This patient may have left side heart failure. Okay, next.
Higher functions.
Sir,
Can this patient may have polyuria? Polyuria. Hypertension can cause diabetes.
yes.
Hyperthyroidism can cause increased blood sugar level. So this patient may present with polyuria, and first diagnosis of diabetes can come in course of diagnosis of hyperthyroidism. Okay, because you already have increased appetite.
Because it increases the sympathetic, effect of sympathetic.
Then comes the neural symptoms. This is a very important area. You should be methodical in asking neural symptoms.
Sir, neural symptoms are patient present with tremors.
Before tremor,
Sir,
before tremor, you're talking to the patient. Patient may be irritable. Patient may not be talking to you properly. Okay, patient may be restless.
Agitated, sharp state of mind, easily getting angry. Patient will complain of loss of sleep. Family members will say that patient is quarreling with everyone.
Yes. Insomnia.
Just provocation.
And then comes the tremor.
Tremors.
Yes. What else?
Sir, akinesia.
What akinesia? Patient is hyperkinetic.
Yes, sir.
It's not akinesia, but there is something. You ask the patient whether he has got any difficulty in standing up from the sitting posture.
Why do you ask this? Why do you ask this? Proximal myopathies.
Proximal myopathy.
Then
patient may have swelling in the legs. Why? Why patient may have swelling in the legs? Both legs patient may have swelling. What is that condition? Yes. So you ask the patient whether swelling in the legs or not. Patient may have changes in the nails. What is that called as? Thyroid acropathy.
Painful swelling of unilateral unidigital clubbing may be there, which could be painful. So that is thyroid acropathy.
You asked about menstrual history. Why menstrual history is important in thyroid disease?
Sir, in case of hyper, there is amenorrhea or
yes.
oligomenorrhea.
Yes, in hyperthyroidism, there is hypomenorrhea or amenorrhea.
Secondary amenorrhea, you mentioned secondary amenorrhea also sometimes.
What happens in hypothyroidism?
So, menorrhagia.
Menorrhagia. Or sometimes in extreme hypothyroidism, patient may have amenorrhea also.
Menometrorrhagia. Regular. Okay. Then metabolic heat intolerance.
Heat intolerance, increase loss of weight.
No, to ho gaya. Heat intolerance and hyperhidrosis.
Yes.
Increase sweating.
Warm, sweaty. You can diagnose a patient of hypothyroidism while talking over the phone and hyperthyroidism while shaking hand. Okay. So you have asked about
what distant metastasis symptom you asked to say patient has no symptoms as a distant metastasis. If you take a thyroid malignancy, you are most commonly seeing the differential thyroid cancer. So what are the feature you have asked to say that patient has no symptom of distant metastasis? These are for discussion. It's good way of writing one line rather than writing all the symptoms. Let the examiner ask you what are the symptoms you asked to say that no distant metastasis. What have you in your mind? Why does a different thyroid cancer metastasize or medullary thyroid cancer metastasize?
Sir, bone pain will be there, sir. And sir,
First metastasis is blood-borne. That is one you are trying to say.
yes,
So if it is blood-borne, it may go to
sir, bone, liver.
bone. So what will be the symptom? Bone metastasis symptom.
Sir, a patient will present with bone pain.
You have to specify. If it is bone pain for 20 years, it's unrelated metastasis. Recent onset bone pain.
Yes.
Maybe aches and pain in the limbs or in the low backache. Then
Sir, then jaundice, sir.
bone pain. Then it may spread to. If it is spread to liver, is the jaundice first manifestation? Understand? Everybody say jaundice and jaundice for liver metastasis, but if you keep in mind that extensive liver metastasis, when more than 70% liver function is compromised, then patient may have jaundice. Otherwise, jaundice may not be a feature of liver metastasis. But yes, you should ask whether the patient has jaundice or not. Then another common site is before liver, the next common site is lungs.
Lungs, sir, lungs.
So, what symptom?
The lungs are any history of hemoptysis. Sir,
In lung metastasis, patient may have pleuritic type of chest pain.
Pleuritic chest pain.
Then cough,
Persistent cough.
hemoptysis. Patient may have breathlessness. Okay. In very advanced cases, patient may have pleural effusion. Okay. So patient may have breathlessness. Then,
sir, CNS.
yes.
Sir, patient.
Another common site is brain. So what are the symptoms the patient has got a brain metastasis? What do you ask from the patient? What happened? That is the brain metastasis. The first change is increased intracranial pressure. That is one. Symptoms due to increased ICP.
Yes,
And then this metastasis occur to a site in the brain where there is an important locus of function. So there may be some focal neurological deficit. So what symptom you ask from the patient to say, yes, this patient does not have a cerebral metastasis.
Sir, patient present with episode of seizures.
Yeah, I given you division. Features of increased intracranial pressure. What is the first symptom patient complain of?
Sir, headache.
Headache.
Yes.
Headache.
Yes.
Vomiting.
Yes.
And this vomiting may come without nausea. And some patient may develop papilledema. So patient may have blurring of vision because of papilledema. And then comes a seizure. Yes. Patient may have convulsion. What else symptom patient may have?
When we are asking about features of hyperthyroidism also, there also you ask about difficulty in seeing, blurring of vision, diplopia, because eye signs sometimes come later. We will find out, and the patient may have symptoms and no signs. So, or the reverse may be true also. Sometimes patient may have signs but no symptoms. So you have to ask about diplopia, blurring of vision, epiphora, all these things for hyperthyroidism also. Okay. Now you've asked about voice, dysphagia, dyspnea, and stridor. Why have you asked these?
Sir, to rule out the compressive symptoms.
This can be either compressive or infiltrative symptom.
Yes.
Okay. If it is a large goiter, that can cause compression. If it is a malignant goiter, it can infiltrate underlying structures. So these two
even if it is a 3x3, like you have said, it is a small nodule, 3x3 centimeter. In such a nodule, if there is voice change, you will think it is not due to compression, but due to direct infiltration of the nerve. Yes. So there it will ring a bell with you that this could be malignant. Next. What surgery is important to ask about in this case?
Sir, surgery, sir, in case of medullary thyroid carcinoma, sir, we ask for adrenalectomy, sir. Or sir.
Okay.
In that case, we have other symptoms.
Yeah.
You cannot just say patient has got pheochromocytoma and patient has no symptom earlier. This is unlikely to happen. Okay.
First of all, when you are approaching a thyroid patient, you should know whether the patient has the entire thyroid intact or not, whether half of the thyroid has been taken out in the past. Yes. So, history of hemithyroidectomy.
Yes.
Okay. So that will help you plan your treatment. Okay. So, regarding medication, what is important?
Sir,
what do you ask?
There are some drugs which can cause a form of goiter. Some neuropsychiatric
Yes, sir.
medication.
Lithium,
Lithium,
amiodarone, all these things.
amiodarone.
And apart from that, you have to find out whether the patient is taking any thyroid supplements or anti-thyroid drugs.
Yes.
That you can ask the patient.
I think this history is not required. This can go usually with the past history.
Past
Relevant
history.
medical and surgical
Yeah.
history. This is a new line I'm finding you are adding. You put past history
Past history. Yeah.
or drug history in the past history.
Hmm.
Okay. Hello.
For hypothyroidism, patient takes thyroid supplementation generally once a day before breakfast. And if
Most of the patient can tell you.
thyroid drugs,
Most of the patient can tell you that patient is on some thyroid supplement. They even know the name of the drug.
That you have to ask specifically. Okay. Next. This is okay.
Yeah, in menstrual history, you should keep in mind that in personal history, menstrual history is the important part of the history. Okay, so you should clearly write about this. If you was a woman, you should give the menstrual history because this is another important area. No issue of similar illness.
What
This
do you
line
mean
is
by
not
similar
perfect.
illness? This is not acceptable.
Family history is
Because-
important. You see, in family history, in thyroid disorder, it can be an endemic goiter.
Yes, sir.
Number two, it can be something which is genetically linked.
Familial or genetic, yes.
Okay,
Yes, sir.
so it can
So
be
it has to be
something
more
which is due to
specific.
Amian syndrome. So in family history, you have to ask, just suppose this is a benign thyroid nodule. How do you explain no issue of similar illness in the family? So you don't have a diagnosis at this stage. So at this stage, your idea is to ask whether any other member of the family has any other thyroid disease. Anyone underwent any surgery for thyroid disease? Anyone under surgery for any abdominal problems? Patient may not be knowing the exact nature of the disease, but
You may ask certain specific things like no history of neck swelling in the family or in the locality also. Endemic goiter is not only in the family, but also in the locality. Then if you're asking about familial cancers, you say that there is no history of, like sir said, surgery in any young member of the family for a genetic mutation, like prophylactic thyroidectomy has been done in some patient, in some family member or not that. Then you have to think about the common cancer syndromes, endocrine cancer syndromes like men. So you ask there that the patient, think about, if you're thinking about medullary thyroid cancer, then you'd say the patient did not have any history of moans, groans, jo parathyroid ka hai, wo bata do. The patient did not have history of abdominal pain, fractures due to minimal trauma. The patient did not have history of recurrent kidney stones or any neuropsychiatric symptoms. Like that, you cover parathyroid. Then you say the patient did not have episodic hypertension or paroxysms of hypertension or headache or diaphoresis. So you rule out pheochromocytoma by history. Then it could be men 1, non-medullary, familial thyroid cancers, papillary and follicular. There you ask about pituitary and pancreas also. No history of loss of consciousness or any hypoglycemia, documented hypoglycemia. There is no history of increased growth of the jaw or the extremities, like you rule out acromegaly, all those things. So instead of writing no history of similar illness, presentations could be different. One family member may come with a thyroid swelling, other family member may have come with a parathyroid or an adrenal swelling, thyroid might be normal. So similar illness does not make too much sense in this context. Okay.
Yes.
Keep in mind that thyroid is an important case in the exam. And if you get a thyroid case, you have a lot of things to present and you have liberty to take the examiner to different areas. So you should be very confident about the history presentation. And then examination is the next part. I think we can go to the examination.
Yes.
Physical examination, sir. My patient is examined under well-lit room with proper consent and with female attendance. Sir. Patient is conscious, alert, cooperative, oriented to time, place, person. Karnofsky score is 90. BMI is 21. Decubitus of choice. Well hydrated, no pallor, jaundice, clubbing, cyanosis, pituitary edema. No engorged neck veins, generalized lymphadenopathy, and left clavicular node. No evidence of toxic eye signs and tremors in the hand, outstretched hand and tongue. Sir, vital signs are essentially normal. Sir, examination of the neck, inspection. There is a swelling in the right side of neck, which moves up with deglutition, which was a single ovoid swelling of size about 3 × 3 centimeter over the right side of anterior aspect of the neck. Vertical extent is approximately 3 centimeter below the thyroid notch and 2 centimeter above the suprasternal notch. Horizontal extensor from midline to 1 centimeter medial to anterior border of the right sternocleidomastoid muscle. All borders are visible and look well defined. Surface appears smooth. Skin over the swelling become normal. Does not move with protrusion of tongue. No other visible swelling in the neck, trachea and midline. So on palpation, in sitting position, well, with neck slightly flexed, patient is first examined from the back and then from the front. No localized warmth or tenderness. Single ovoid swelling of size 3 × 3 centimeter over the right side of sternocleidomastoid muscle. Vertical extent is 3 centimeter below the thyroid notch and 2 centimeter above the suprasternal notch. Horizontal extent from the midline to 1 centimeter medial to the anterior border of the right sternocleidomastoid muscle. Surface is smooth, border is well defined, consistency firm, freely mobile in all directions. Skin over the swelling is normal. There is no thrill. Bilateral carotid pulse palpable. Examined one at a time. Trachea in the midline. Lymph node examination, no cervical lymphadenopathy. Oral cavity examination was normal. On percussion, no retrosternal dullness. Auscultation, no blue over the swelling. So systemic examination is essentially normal. Summary. 34-year-old lady with swelling for last 1 year in front of the neck, insidious in onset, gradually progressing about 1 × 1 centimeter, 3 × 3 centimeter, presently with no symptoms suggestive of hyper and hypothyroidism or constitutional or compressive symptoms. On examination, there is a single form swelling of size 3 × 3 centimeter in the region of the thyroid, which is firm in consistency, moves with deglutition, mobile in all direction with no cervical lymphadenopathy. So my provisional diagnosis is that this is a 34-year-old lady with solitary thyroid nodule, likely to be benign etiology involving the right lobe of the thyroid gland, with patient in euthyroid state.
Go back to the initial slides. Decubitus of no choice বলা ভালো না?
Yes. Decubitus of any choice. Decubitus of any choice.
Yes.
That is the correct sentence. And here in the neck, cervical lymph node, you can comment that cervical lymph node examined under local examination.
Naked part gulo can be written as, that has been examined along with local examination later. Okay. You have to mention about the vitals. Vitals you have mentioned.
Yes. Now I'll point out one your mistake in the inspection, because the picture is not there. Come inspection. If you see the 3 centimeters in the right lower thyroid gland, what is the distance between the medial border sternamastoid and the midline? Hardly 1 centimeter. And if you have a 3 centimeter swelling, it is unlikely that you find the lateral border of the swelling is once in the middle of the sternamastoid. This cannot happen because the right lobe is overhang by the sternamastoid. The swelling that is coming up from the right lobe will elevate the sternamastoid, and if it is going to the midline, there will be no cleavage between the medial sternamastoid and the swelling. What you are writing? From midline to once in the middle and sternamastoid. What is the right lobe? If you are saying something is ending once in the middle sternamastoid, this cannot be the right lobe. This has to be the isthmus. Whole right lobe is almost overlaid by sternamastoid. So this cannot happen because patient will be in front of you.
The entire space between the trachea and the sternocleidomastoid will be taken up by the.
Yeah, there cannot be a cleavage. There you cannot find a medial sternomastoid and then gap of 1 centimeter and then the swelling. This
Oh.
cannot happen from a swelling in the right lower thyroid gland. Rather, you can say that the swelling extending deep to the sternomastoid and some large swelling can go even up to the posterior border of sternomastoid. That is important. Okay, your
In
description
this,
has to be
the examiners tend to ask one question: why does it move up with deglutition? You must know the reason why it moves up with deglutition, the swelling.
The thyroid gland is enclosed with pretracheal fascia, which posteromedially condense to form a Berry's ligament, which is attached to cricoid cartilage in the above and lower to the trachea. And while deglutition, it moves along with cricoid cartilage and
what happens during deglutition with the larynx? What happens to the larynx on deglutition?
so it moves.
It moves up. Why? Why does the larynx moves up during deglutition? What happens during deglutition? You are eating.
What happens to
So-
the laryngopharyngeal complex?
So during eating, this food has to go to the esophagus,
Sir,
not to the larynx. So as the larynx moves up,
yes,
this
the closer of
yes. So that is the reason that larynx is moving up and thyroid being attached to the larynx
yes.
and the trachea, it moves
Also
up.
moves up.
That is the explanation. Only Berry's ligament is not the factor.
Yes.
Berry's ligament is a condensation. Apart from this, all the pretracheal fascia is getting attached to the larynx and trachea.
The entire thing is like laryngopharyngeal complex. When you are doing deglutition, the pharynx is attached to the base of skull, okay, with the median raphe. So it moves up. Since the larynx and pharynx forms a complex, and the larynx has to close when the patient is deglutition, doing deglutition, the larynx also moves up along with it. And as a result, the thyroid moves up. Okay. Next.
And you have done the protrusion of tongue test. Keep in mind for other case, if you have a solitary thyroid nodule, you do the test.
You must do.
If you have a diffuse thyroid swelling involving both lobes, don't utter this stage I've done protrusion of tongue. Because in that case, I'm not trying to differentiate this swelling from a thyroglossal cyst. So if it's a diffuse thyroid swelling involving the both lobes and isthmus, multinuclear goiter, don't say I've done the tongue protrusion test. That is not required.
No, here when you are doing clinical examination and reporting the findings, there you be specific about what visible swelling in the neck you are talking about. No other visible swelling. You mean lymphadenopathy, right?
Yeah.
So write that. There are no lymph nodes, and be specific. There are no lymph nodes in level 2, 3, 4, 5. Then the examiner can ask you, what do you mean by level 2, 3, 4, 5? Okay.
And also in inspection, unless there is gross lymphadenopathy, you can skip this line also.
Yes.
Because on inspection, it's difficult to make out the lymphadenopathy unless it's a very gross lymphadenopathy.
We feel lymphadenopathy by palpation only. Unless there is like very big, that is the main presentation. Sometimes patients will present with bulky lymphadenopathy only, and the thyroid may be very small. So then it is okay. But otherwise, generally we will find out lymph nodes by palpation only. So it's not needed to be mentioned in the inspection. Trachea in midline is fine, but as I told you, when you are describing the swelling, you describe it with respect to the trachea. So you start trachea is central and the swelling is completely on the right side of the trachea.
Yeah.
So it is a right STL. Okay, next. So first you have examined from back and then from front. Why? Achha, in inspection, Pizillo's method is also asked. If the patient has a short neck, what will you do? Or what is Pizillo's method? So you must know that also. Do you know it?
Yes. Sir, Pizillo's method is done for short neck of the obese individual. Sir, in that, sir, a patient is asked to put both the hand over the back of the or the occiput, and then and with neck.
Not only put and apply pressure. Put both hands on the occiput and apply pressure.
And try to extend the neck.
Try to extend the neck.
Okay. Now coming to palpation, you have examined from the back as well as from the front. So what are these two methods?
Sir, from the front, sir, sir, it's called Lahey's method, sir.
What is the difference between Lahey's method and the classical method? What extra information do you get from the Lahey's method?
Sir, anterolateral surface and posterior surface both can be felt, sir.
Yes, anterolateral, posteromedial the surface which remains hidden. When you apply pressure in Lahey's, what you are doing? You are applying pressure on one lobe and feeling the other. So the posterior border and part of the posteromedial surface becomes
Prominent.
palpable.
Yes.
You get access to that area with your fingers. And in classical method, you are just supporting one lobe and palpating the other. Okay. Suppose the nodule is very small and on the isthmus specifically. Then how do you try to look for such a nodule?
Sir, if it's a small nodule, sir, we'll do, sir, Ryle's method, where we put pulp of the finger over the swelling and ask the patient to swallow, sir. The swelling will move with up and down, feel the surface of the swelling.
So why did you look for localized warmth or tenderness?
Sir,
Which thyroid gland may be vascular?
Sir, in case of, sir, Graves' disease, sir.
Yes.
If you use toxic goiter or Graves' disease, you may have a warm gland. Okay. Then this needs to be corrected, as sir said, 1 centimeter medial to anterior border of right sternocleidomastoid, not possible physically.
Yes, sir.
Okay. Then surface is smooth. What other surfaces can you find? Not in this case.
Sir,
Thyroid has got three surfaces: anterior surface,
yes, sir.
medial surface, and posterior surface.
Yes, sir.
Medial surface you cannot palpate; it is abutting on the trachea surface.
Yes.
So anterior surface you can palpate, and by pressing this thyroid lobe, you can palpate the posterior surface in two ways. If it is small swelling, you can insinuate finger between the sternomastoid and the swelling itself. Or if it is a large swelling to the posterior sternomastoid, you can go behind the sternomastoid and palpate at the posterior border of sternocleidomastoid. Okay.
How do you look for mobility? What do you mean by mobile in all directions?
Sir, up and down, and sir.
First is, try to understand, there are two things in mobility. You put your finger and ask the patient to swallow.
Yes.
The swelling moves up and down deglutition. What's your interpretation?
Sir, sir, it is.
Interpretation is,
Sir,
as you ask the patient to swallow, the swelling moves up and down. I have got one inference out of this. Inference is?
Thyroid swelling, sir.
No, that is part.
Yes, sir.
In regard to mobility, I can make inference that this swelling is not fixed to the underlying prevertebral muscle and the vertebral body. Got my point?
Yes.
In relaxed state, I ask the patient to swallow and I can feel the swelling up and down in deglutition.
Yes.
This swelling can still be fixed to the larynx and trachea.
Yes, sir.
Suppose a malignant swelling, it has infiltrated into the trachea and larynx. It will still move up and down deglutition. Now, how to differentiate? The swelling is not fixed to the underlying larynx and trachea. That is the intrinsic mobility. You try to say in all directions. That means it's not a deglutition movement you are testing. Now the swelling is as such in profile. You try to move the swelling.
Yes, sir.
You cannot move. Now you are trying to move the whole larynx and trachea is moving with the swelling. That means the swelling is fixed to the larynx. These are the two things. Skin fixation is obvious. You can whether you can pinch up the skin or not. Okay. So the important thing is movement with deglutition, which will indicate whether the swelling is fixed to the underlying prevertebral muscle and vertebral body. Second is intrinsic mobility. Try to move the swelling, whether the swelling is moving without displacement of the larynx and trachea.
Yes. So you have written no thrill. Where have you looked for thrill?
Sir, sir,
Look for means where have you palpated for thrill?
sir, in upper pole of the thyroid swelling, thyroid gland.
Why?
Sir, because, sir.
Why do you put the stethoscope in the upper pole?
Sir, because, sir, Sir, upper pole had, sir, superior pedicle, sir, which
Upper
more,
pole is superficial.
yes,
It
sir,
comes closest to
more
the
anterior and, sir,
So when you are palpating, you palpate for a thrill, and when you auscultate that, it becomes a bruit.
yes.
Especially in cases of Graves' disease, you may have it. So since the upper pole is superficial and there is maximum, hyperdynamic circulation in the upper pole of thyroid with angiogenesis, new angiogenesis occurs in Graves' disease. All of that occurs more in the upper pole. So you look for thrill in the upper pole. So where have you looked for the carotid pulse?
Sir, carotid pulse,
Normal
sir,
location.
uh, sir, at the level of, sir, upper border of thyroid cartilage, to the, along the, sir, sternocleidomastoid, anterior border of the sternocleidomastoid.
That is one surface marking. Another important surface
Yes, sir,
marking is
is,
there at the level of cricket cartilage, where the carotid tubercle is there. You go to the upper thyroid cartilage, that is a site where the carotid bifurcates.
Bifurcation.
The better site to palpate is at the level of cricket cartilage, where you can palpate the common carotid against the carotid tubercle.
You go laterally, and at the anterior border of the sternocleidomastoid, you can feel. Okay. So if you do not feel the carotid pulse at its usual position, then what would be your inference?
Sir, if
Carotid is not filled in the normal site.
yes, sir.
So two possibility. What are the two possibility?
Sir,
It is either displaced
or
or it is engulfed,
encased, sir.
encased.
Yes.
So if it is displaced, how do you find? Displacement occur in a
Sir,
very large
large
goiter.
goiter. Yes, sir.
Disseminated goiter is unlikely to cause displacement of the carotid. If it is a large goiter, this can displace.
Yes.
Small goiter, pulse is not palpable. It is
Any
likely that there is infiltration and engulfing of the carotid.
Carotid sheath engulfment. So that is called very sign positive, right?
Yes, sir.
So again, you have mentioned trachea in the midline. What special test have you done to rule out any incipient tracheal compression?
Sir, so we put index and
This is the patient who has got a swelling in the right lower thyroid gland. Do you expect that this is likely to cause tracheal narrowing?
no,
Very
sir.
unlikely.
Yes,
Why
sir.
not? Because
Sir,
What can happen? This can push the trachea.
yes, sir.
Patient does not have any other symptoms. And even if there is a features of some imminent tracheal compromise, as Dr. Moitra is asking, will you do any test to demonstrate that?
Sir, focus test.
Will you do it?
Sir, in this case, sir, not.
No, not in this case. Suppose there is a swelling on either side, patient has some symptoms of stridor. Will you like to demonstrate whether this test is positive or not? This test is not to be done.
Not to be done, sir.
Then
It
how
is
do you demonstrate? Yes, there is a tracheal compression.
to be condemned. It is mentioned to be condemned, okay? Because you will you
But
are
you
in
have
an
to
examination
confirm
hall.
this.
You are in an
All the-
examination hall, and suddenly you will try to do that test, and patient will start having stridor. Then it will be very difficult to manage. So you should not do any provocative test in the exam, okay? But you mentioned this can be done, but I have not done because I didn't want. So what is the answer to sir's question? How will you confirm?
A plain X-ray.
Yes, sir.
A plain X-ray can show soft tissue shadow causing tracheal luminary and confirmed by
What? What do we do before surgery? Sometimes we do this.
Sir,
In
indirect.
all cases, you do an indirect laryngoscopy, and sometimes you may do a direct tracheoscopy. Okay.
Yeah.
And if there is a malignant swelling with tracheal infiltration, you can do a tracheoscopic biopsy also. So that is separate thing. Think of common things first. X-ray should come to your mind. And when sir asks that question, that is the first thing that should come to your mind. Okay, next. So how have you done the lymph node examination?
Sir, 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 level one is submental in the submental triangle, sir.
Do you
Level two,
expect any submental swelling or submandibular swelling in a thyroid?
no, sir.
So 1A, 1B is not important.
Sir,
In
two,
thyroid?
sir, 2, 3.
Or is the limit of 2, 3, 4? Just give an idea. If you take the jugular vein exiting from the skull base,
Yes, sir.
from there, if you take the, because these are all along the interjugular vein.
Yes.
Hmm.
So if you take this, what are the, at least an approximate idea, yes, this is the level 2, this is level 3, this is level 4. If you go by just surface marking, is 1/3, 1/3, 1/3. So measure the distance between the sternoclavicular joint and the mastoid, where the jugular vein is coming. And upper third, mid third, lower third. Again, there are some underlying marking also.
There are imaginary lines which are drawn from the tip of the thyroid cartilage, then cricoid, okay, and you are supposed to go laterally, and that divides the internal jugular vein. So accordingly, you divide level 2 above that, 2 and 3 between those 2, and 4 below. Okay.
And in the examination, if you have toxic goiter, suppose you are facing a case of Graves' disease, in that case, you make a separate heading for examination for toxic signs. You start with pulse, pressure of the pulse. You start with eye signs. You start with tremors. You start with peteval myxedema, thyroid ectopechy, and examination for proximal myopathy. So, in otherwise, no symptom happening is not required. But if you are having a question of Graves' disease in the exam, this point should be separately shown, that examination for toxic signs.
Yes.
I think this one you can discuss some management. 10 minutes more.
The
So diagnosis.
retrosternal prolongation term. In this case, since the lower border is already visible,
Yeah.
So you didn't do. But if the lower
He
border
said,
is not visible,
yes.
then you ask the patient to do deglutition. If the lower border becomes visible after deglutition, then you know there is minor retrosternal prolongation, which is overcome during deglutition. And if you cannot appreciate the lower border even on deglutition, then you ask the patient to do Pemberton sign, like you do Pemberton sign. You ask the patient to raise both arms and touching the ear lobules and keep it like that for 1 minute, and then you see. Okay. So now your diagnosis is a solitary thyroid nodule, right side.
Yes.
So how will you start investigating the patient?
What do you mean by solitary thyroid nodule?
Sir, solitary thyroid nodule, sir, it is, sir, discrete swelling with otherwise impalpable glands.
Not immediate cancer.
Sir, no
Solitary
other-
thyroid nodule is what?
Sir.
It says swelling in the thyroid gland.
Yes, sir.
Okay.
Yes.
And you are palpating a nodule. The rest of the thyroid gland is
No.
thyroid is normal.
Yes, sir.
So you also described as an isolated thyroid swelling. And what is the dominant thyroid nodule?
Solitary thyroid nodule is a clinical finding. Okay. From history and examination, you can say whether it is benign or malignant. It could be both.
Yeah.
And if there are features of toxicity along with a solitary thyroid nodule, then you say it is a toxic adenoma. All possibilities are there.
What is dominant nodule?
Sir, dominant nodule, sir, a larger nodule with other clinically palpable nodules.
It may not be clinical palpable also.
Sir, clinical or sir, radiolo.
It's a dominant nodule means is a predominant nodule with palpable abnormality in the rest of the thyroid gland. That is dominant nodule. So fine, this is a solitary thyroid nodule. How will you approach?
Thyroid nodule and patient is non-toxic. In spite of that, you have to ascertain the thyroid status of the patient. So you will do T3, T4, TSH.
And always keep in mind that these 3 points has to be there in thyroid diagnosis. One is what is the likely pathologic nature of the swelling.
Yes.
Second is benign or malignant, and next is the thyroid status, functional status. So these 3 things should be there in the thyroid diagnosis. Okay, how will you proceed?
So you will do T3, T4, TSH. Suppose TSH is normal, T4 is normal, means it is a euthyroid patient. Next, what you will do?
Sir, I'll do, sir, ultrasonography of thyroid.
Last day I discussed,
I-
faculty lecture.
Sir,
High
it was
resolution
always you
ultrasound.
start with that, I'll do the quadruple assessment. Quadruple assessment, one is clinical examination I have done.
Yes, sir.
Next is a thyroid profile.
Yes, sir.
And as screening, if the patient is not having symptoms of hyperthyroidism, I can do just a TSH study.
Yes, sir.
But there are some examiners who have the facility of saying, no, you have to do both T3, T4, be flexible.
Yes, sir.
If some examiner the habit of saying you have to do T3, T4, TSH,
TSH is good enough. TSH is good enough to tell you, but some
otherwise, in the
examiners-
book, it is written that TSH is a baseline marker you study. And TSH, you find CHS low, yes, do the free T4, total T4, T3, yes.
Yes, sir.
Okay.
especially if a patient is on thyroid medications,
Yeah.
then FT4 and TSH assessment together becomes helpful. If the patient is not taking any drugs, only TSH will help. Okay. Then
Next.
sometimes nowadays they are saying that genetic tests is also included in quadruple assessment. They are
Yeah.
leaving out TSH and they're saying ultrasound, FNAC, and then genetic test and clinical examination history. These four are parts of quadruple. So some books are coming up with this.
Yes,
So
yes.
don't know.
Genetic marker is now being added
Yes.
as part of quadruple assessment.
Yes.
Because
So
it's because you have to differentiate mainly, come to the next part. Is usually ultrasound.
ultrasound also you be specific. High resolution ultrasound using a linear probe with frequency 6 to 13. Preferably 10 to 11 for thyroid. Okay, be specific. Because in thyroid, etc., you are expected to do the ultrasound yourself also. Okay, so you have done ultrasound. So generally, when we have done ultrasound, we have two kinds of reporting. One is the SCR TIRADS, American College of Radiologists TIRADS, and also the ATA way of presenting your findings. Okay, there is a Korean TIRADS also, which we do not often follow. So which one do you follow? ATA or SCR TIRADS?
Sir, here tired.
ACR TIRADS. So what are the different parameters that you see to assign TIRADS score to a patient?
T1 is a normal thyroid gland, sir. T2 are benign. T3 is probably benign. 4 is suspicious lesions. 5th is
TIRADS, I have asked what are the parameters you see. First, you have to look at certain parameters on ultrasound. Echogenicity.
yes, sir.
Whether it
Echogenicity.
is anechoic, hypoechoic, hyperechoic, or very hypoechoic. What is the consistency? Whether it is cystic, solid, or spongiform.
Yes, sir.
Whether what about the margins? Whether the margin is well defined, irregular margin, or whether it is elevated, or whether there is exothyroid extension. What about echogenic foci within the thyroid swelling? Whether there is a comet tail defect, whether there is peripheral rim calcification, there is microcalcification, all these things. Whether it is wider than tall. So these are the different characteristics. There are scores for each. Suppose it is anechoic, you give 0. It is hypoechoic 1. Hyperechoic 1, hypoechoic 2, very hypoechoic 3. Like that, there are scores for everything. You add up the scores and then finally give either thyroid 0, 1, 2, 3, 4, 5, like that. Now, depending on the thyroid's class, you decide which needs FNAC and which does not need FNAC. Like for a thyroid's 5, you need to do FNAC for a nodule more than 1 centimeter. For thyroid's 4, you need to do FNAC for a nodule more than 1.5 centimeter. For a thyroid's 3, you need to do FNAC in a nodule more than 2.5 centimeter. For thyroid's 1 and 2, you do not need to do anything. You just give the patient a follow-up. Again, if you follow the ATA way of reporting, then they classify into highly suspicious, intermediate suspicion, low suspicion, very low suspicion. If it is high or intermediate suspicion, you do FNAC if the size of nodule is more than 1 centimeter. For low suspicion, you do FNAC if it is more than 5 centimeter, and you do FNAC in a very low suspicious nodule if the size is more than 2 centimeters. So these are the two criteria. Now you have decided this is a 3 into 3 centimeter, and suppose on ultrasound, even if it is very low suspicious, because it is 3 into 3, you have to do FNAC. Okay. And apart from these findings, there could be cystic swelling. If it is a pure cyst, simple cyst, You aspirate it, do a therapeutic aspiration. If there is no blood, you do not do anything. If blood comes out on aspiration, then you do a cytology and you allow reaccumulation up to 3 times before you decide to remove the lobe. Or if it is a definitely benign nodule, then also you just keep it on follow-up.
Yes.
Now, once you have done FNAC, how do you report the FNAC findings or interpret the FNAC findings?
Sir,
You have done FNAB, and what you should do, either ultrasound guided or non-guided FNAB.
we should do, sir, ultrasound.
Always.
Always ultrasound guided. Very good.
But there are some areas people are saying that if it's a very large nodule,
The completely
easily
solid.
palpable, but most of the time it's the ultrasound guided.
Yes, sir.
What is the system of reporting in in this FNAB?
Sir, Bethesda classification.
Bethesda system of reporting.
Bethesda 1 is
Sir,
non-diagnostic or
non-diagnostic.
inconclusive.
Yes,
So
sir.
in Bethesda 1, what is suggested? If you have done a blind FNAC, do an USG guided FNAC. If you have already done USG guided FNAC, then either you do a repeat USG guided FNAC or you may keep the patient on follow-up, or later on you may even have to do a diagnostic lobectomy if it is coming out to be Bethesda 1 repeatedly. Now comes Bethesda 2.
Yes, sir.
Which is our topic of discussion today. So what is the commonest etiology of Bethesda 2? Hashimoto's thyroiditis. Okay, 45% is Hashimoto's disease in Bethesda 2. Now, if this is a Bethesda 2, it has come out on FNAC, Bethesda 2. What will you do? How will you decide patient needs follow-up or surgery? Bethesda 2 is benign.
Colloid nodule,
Yes,
colloid nodule, a adenoma in the gland.
yes.
Okay. 3 centimeter size is what? For observation? For surgery?
Sir, for observation. Sir.
No.
No.
3
What
centimeter
are the
swelling.
indications of surgery?
Because yeah, I mentioned last in my lecture, when the nodule size is getting bigger, the chance of false negative is higher.
Yes. What is the false negative rate in FNAC? 1 to 6% sometimes. Okay. So it is a 3 into 3 centimeter nodule. So what are the indications of surgery? One is cosmetic concern, lady, 34-year-old. So cosmetic concern. 2 is compressive features. If they are present, you have to operate. Number 3 is fear of cancer. This swelling was 1 into 1 last year, and this year it is 3 into 3. So patient may have fear of cancer. So these are the common indications of surgery. However, if you choose not to operate, then how frequently will you do follow-up? Suppose it was a smaller nodule. It has come out to be benign. Do you just let the patient be, or you follow a system of follow-up?
Yes, sir. Initially, sir, patient is asked to follow up to 6 months. Then, sir,
What do you do
There is
at
a
follow-up?
protocol for that also. Suppose you did an FNAC and it came out to be benign. But since you have done FNAC, in the initial ultrasound, it must have been either highly suspicious or intermediate suspicious or low or very low suspicious, but some suspicion was there. So on follow-up, if it was a highly suspicious nodule or an intermediate suspicious nodule, and you have done FNAC to find out that it is benign, then you have to do an ultrasound within 3 to 6 months.
yes.
If it was a low suspicious nodule and on FNAC you found it to be Bethesda 2, then you repeat an ultrasound within 12 to 24 months. And if it was a very low suspicious nodule and it came out to be benign, but the Bethesda 2 on FNAC, then you repeat an ultrasound not before 24 months. This is how the recommendation is. Now you do an ultrasound. Then how do you decide that on follow-up ultrasound, there are certain features on the basis of which I will need to repeat FNAC again? So what are those features?
Sir, whether the size of nodule is
How much? There is objective criteria for everything. If there is increase of size of the nodule by 50%,
yes, sir.
or by 20% in any 2 dimensions, overall volume of nodule, suppose it increases by 50%, or if any 2 dimensions increase by 20%. So suppose it was 4 centimeter, now it has become 5 centimeter. In big nodules, we wouldn't do observation anyway. Suppose it is a 2 centimeter nodule and now it has become more than 2.4. around 2.5. Then you will think I need to repeat FNAC again. Then again you repeat FNAC, and then again you see what has come out, whether it has come out as Bethesda 2. If it has come out as Bethesda 2, again you follow the same protocol for follow-up. If it comes out to be Bethesda 3 or 4 now, then how will you change your planning? What do you mean by Bethesda 3 and 4?
Now comes a question of indeterminate FNAB report.
Yes.
So what is the recent addition to this?
Sir, genetic testing.
Yes.
What genetic testing will you do?
Sir, we'll do genetic testing for BRAF.
No, it is called a 7-gene panel. 7-gene panel. It includes BRAF, PAX8, PPAR gamma, red PTC, and all the fractions of RAS, RAS, KRAS, HRAS.
Yes, sir. Yes.
Okay. So PAX8, PPAR gamma is particularly helpful in Bethesda 4, where you are not being able to differentiate between follicular adenoma and follicular carcinoma. PAX8, PPAR gamma helps in that differentiation. In Bethesda 3, where it is atopy of unknown significance or follicular lesion of unknown significance, there the other tests are helpful. If you have a genetic mutation and an indeterminate FNAC, then you will decide to do surgery.
Yes.
And preferably, if there are very high risk mutations present, you will do a total thyroidectomy.
Yes.
If there are low risk mutations or absent low risk mutations, you may still do a lobectomy and do completion thyroidectomy if needed in future.
Yes.
If there are no mutations, you may just keep the patient on follow-up. That avoids any unnecessary lobectomy also. Okay.
Yes.
And where you do not have genetic test facility, you may repeat an ultrasound guided FNAC, and then as we do diagnostic lobectomy and follow-up. Completion thyroidectomy if needed. Okay, so this is Bethesda 3 and 4 covered. And Bethesda 5, you already know, that is a separate topic altogether, malignant thyroid swelling.
Yeah.
So this is the basic management. Okay.
I think gone beyond time. Okay. Ridwan, thank you.
Thank you, sir.
Any question? Any question from anyone? No, nothing in the chat
Sir,
box.
আপনি কি 3 তারিখে থাকছেন সকালের ক্লাসটায়?
3 তারিখ কি ক্লাস গো?
এখানে একটা ওই এলএআর এর ক্লাস আছে আমার নেক্সট আবার 3 তারিখে।
কোথায়?
হ্যাঁ, আপনি কি আছেন ওই সময়?
3 তারিখে হ্যাঁ আমি থাকবো।
ঠিক আছে।
থাকবো।
3 তারিখটা কি ডেটটা একটু চেঞ্জ করা যায়? ওই দিন না অ্যাকচুয়ালি আমার হসপিটালে একটু তাড়াতাড়ি।
আচ্ছা ঠিক আছে, আমি 2, 3 দুটোই চেঞ্জ করতে হবে তাহলে। চেঞ্জ করে পরে নিচ্ছি।
ঠিক আছে
ঠিক
স্যার।
আছে। হ্যাঁ, পোস্ট করে
তাহলে স্যার
হ্যাঁ
চেঞ্জ করলে 17th to 20th ফেব্রুয়ারি বাদ দিয়ে আমাকে দেবেন।
আচ্ছা ঠিক আছে, ঠিক আছে।
17 থেকে 20 আমি থাকবো না।
ঠিক আছে, ঠিক আছে। Okay.
Thank you, sir.
Thank you. Thank you, sir.
Samantha is also not there, so